Good evening, everybody. Thank you for waiting. We will be starting the session within a minute. And it's my great privilege and honor that today we will have one of the most sought after speakers in the country. And that too on a very, very relevant topic which we fathom in our lives in a day-to-day exercise. So please hold on and we will start. So here I can see Rajesh Bhushan sir on the screen. Most welcome, sir. I hope my voice is going around. Can anybody confirm? Sir, can you hear me?
Of course, I can hear you, I can see you loud and clear, Uttam.
Thank you so much, sir. Much appreciate. So, sir, good evening to everyone in the audience. And it is my great honor to introduce a man who has raised benchmarks towards response to crisis in the world and changed the perception, global perception rather, of our nation. A hero whose leadership during COVID-19 pandemic gave us the confidence that India would not be left behind in times of global challenges. We are privileged to have Rajesh Bhushan sir, the former health secretary, as our keynote speaker for the 16th edition of Reimagining Governance Discourse for Excellence. Sir's guidance, as we all know, was central to India's successful management of the pandemic, focusing on three key pillars, namely containment, relief, and vaccine administration. His efforts in collaborating with the stakeholders, including ASHA workers, to produce essential PPE kits and his leadership in overseeing the administration of over 2.5 billion vaccine doses are a clear testament to his dedication and resilience. All this, as we just saw, with humility, simplicity, and with a contagious smile, the much needed tools of these unprecedented times and today as well. Bhushan sir has always emphasized on evidence-based and agile responses, ensuring that health interventions are not only effective, but are also economically sustainable. His proactive approach to governance and community engagement has set a global benchmark. With roots in Uttarakhand and a distinguished career in the Indian Administrative Services since 1987, Sir has held senior leadership roles in health, education, rural development, and various other sectors. His leadership in the COVID vaccination program earned him the Prime Minister's Award for Excellence in Public Administration in the year 2022. Further, in recognition of this exceptional COVID management, his ministry, the Ministry of Health and Family Welfare, then received the prestigious Porter Prize 2023 that is instituted by Stanford University and the Institute of Competitiveness. Bhushan sir also chaired the Program and Budget Committee of the World Health Assembly in 2022, representing India on the global stage. And before his current role, during the COVID, he served in key positions including Chairman of Food Safety and Standards Authority, Secretary of Ministry of Rural Development, and much more. With such an illustrious career and a significant contribution to public health and governance, it's my once again a privilege to welcome Shri Rajesh Bhushan, sir, to speak to us today. Sir, thank you so much. Please accept our gratitude for the incredible affection that you have shown. And as a very common tradition which we do on this program, sir, we have three of our senior officers at Dehradun to felicitate you. Of course, we wish we could have done it physically, but even online, sir, please allow us to felicitate you right now. may I request Viswajit Sagar sir to please do the honors.
Come.
Thank you so much. Thank you so much, sir. Thank you so much. Picture perfect.
Sure. Yeah. Thanks, sir.
Thank you so much, sir. Much appreciate this. And before I move forward, sir, couple of minutes back, I just received a message from our Central Provident Fund Commissioner that he has been suddenly required to attend to an unscheduled, unavoidable meeting with the Secretary Labor, and he has said that he will attempt to join as soon as possible. So request your permission to allow him that convenience, please, sir. At this
Yes.
moment, thank you, sir. Thank you so much, sir. May I now request our Director of the National Academy of Social Security, Shri Kumar Rohit, to formally welcome Bhushan sir and share his initial thoughts at this moment, please. Rohit sir, please. Sir, we are not getting your audio, Rohit sir.
Are you able to hear me, Uttam?
Yes, sir. Now it is better, sir. Most welcome, sir.
Thank you, Uttam. So good evening again, everyone, and a warm welcome to our keynote speaker for this 16th edition. All senior officers from EPFO, MOLE, and my fellow colleagues. It's my privilege and honor to welcome you to the 16th non-stop edition of this unique governance series initiated by PEDUNAS, Reimagining Governance, Discourse for Excellence. I am also thrilled to introduce our esteemed speaker, Shri Rajesh Bhushan ji, the man who led India through one of the most challenging periods in human history, managing an unprecedented global pandemic. His leadership extended beyond India's borders with the Vaccine Matri program, where he helped 96 countries, truly embodying the core philosophy of Vasudhaiva Kutumbakam. The world is one family. Please join me in extending a warm welcome to our nation's hero, Shri Rajesh Bhushan ji. Shri Bhushan is known for his strategic thinking, his exceptional administrative skills, and his inspiring, warm personality. It's no wonder he is a sought-after speaker on subjects such as managing in uncertain times, a topic that deserves a place in the core curriculum of business schools worldwide. This RGDE series was launched on Good Governance Day in 2023, sir, and has since been a platform where seasoned veterans, including our esteemed speaker, engage with officers from all ranks within EPFO. This series brings insights, ideas, and perspectives to enhance trust in public governance. Encouraged by positive feedback, this initiative is held around the 25th of every month. What sets this series apart is its scale. It is a unique capacity building exercise within the government. Officers from across the country come together on a virtual platform, not only to learn about innovative ideas, but also to discuss ways to implement them effectively. we have seasoned policymakers, administrators, and thought leaders share their insights on cutting-edge technologies, successful governance experiments, and innovative methodologies. The program specifically focuses on accelerating ease of doing business and ease of living, which is directly relevant to improving the lives of citizens. Beyond gaining expert insights, our officers develop well-rounded perspectives. Their active participation sharpens their critical thinking and problem-solving abilities, empowering them to excel in their roles. Regular engagement with thought leaders ensures that EPFO stays at the forefront of discussions on social security, which directly impacts labor well-being and productivity. At EPFO, we recognize that growth and development must prioritize the most vulnerable members of society. That's why we are continually upgrading our skills, and this academy is committed to sharpening them. We aspire to be a partner in the idea of being a soldier of Vishwamitra, learning and sharing best practices, especially with our counterparts in South Asia. And we draw inspiration from vaccine Matri initiatives also. We aim to demonstrate that social welfare need not be the sole domain of the developed world. As the world's fifth largest economy, India's progress has a significant impact, and we are committed to making a real difference globally. Our goal at EPFO is to deliver digitally enabled governance and effective service, walking through enforcement, service delivery, and stakeholders' engagement, all of which move us closer to the nation's vision of social security for all. As I conclude, I leave you with this thought: how important is a people-centered approach to leadership, and especially in a country as diverse as ours, where customized and personalized solutions are key to moving forward as we work towards joining the ranks of developed nations. Thank you, sir, for your time and affection. You are once again most welcome. Jai Bharat.
Thank you so much, sir. Thank you so much, sir. And sir, with your permission, before I move ahead, I would like to share just a few words about the audience here. The audience here, sir, is a very diverse group, and they have joined from about more than 100 locations in the country right now. And this is unique group capable of performing everything from judicial functions to handling complex service delivery tasks, from managing public relations to overseeing large government programs, and many of the times it comes at a short notice. In fact, sir, EPFO is a prime example of an agency that plays a crucial role in India's economic framework. This financial year, sir, as I speak, we have settled around 5.95 crore claims, and more than 45% of these were settled within 3 days. Sir. And to my surprise, sir, as I just Googled and found out, the US Social Security, as it displays on its website, says that it takes 6 to 8 months for a decision to be taken on application for a disability benefit. So we are proud to say that we are improving day by day from the days when we used to handle things on paper. Today, most of our functions are digitally enabled and can be accessed anytime, anywhere. We today serve around 80 lakh pensioners, sir. This is more than all the central government pensioners combined together in the country. And we partner with nearly 8 lakh establishments, and a corpus of 30 lakh crores roughly helps us get a recognition of one of the top 10 sovereign pension funds in the world. So thank you for the kind attention. And I do not need to emphasize that EPFO is a high impact agency of the government. Sir, EPFO is more than just an institution. It is a beacon of hope, a shield against life's uncertainties. EPFO is in the business of navigating the stormy seas of economic uncertainty, the shifting tides of employment trends, and relentless waves of technological change. With these words, I would like to invite Bhushan sir, which gives a very apt topic and a relevant topic for our administrative acumen development as well. So without further loss of time, it is my privilege to request Bhushan sir to take on the stage. All ears to you, sir. Thank you so much.
Thank you. Thank you. Thanks a lot, Director of the Academy, Kumar Rohit, ladies and gentlemen, and friends who have joined from across multiple locations in India. I hope I'm audible.
Very much, sir.
Okay. So before I have a presentation, but before I come to the presentation, there are two things which are important. When we look at India's response to the COVID-19 pandemic, why should we be recounting that tale? There are multiple reasons for it, but let me share with you two important reasons. One, that human mind has this great ability to forget experiences which are less than pleasant. And COVID pandemic definitely was not a pleasant experience. So the mind tends to push it back, and then we tend to forget what happened, the kind of havoc and the unprecedented once in a century challenge that COVID posed before all of us, and how we tackled with it and came out of it with a sense of satisfaction that we optimally utilized our resources. So that is the first reason why discussing such experiences is important. The second reason is that during the COVID pandemic, Government of India, one of the rare occasions, worked as one single homogeneous unit. Different ministries, different departments, different organizations came together and worked with single-mindedness. I could give you two off-the-cuff examples. Department of Financial Services, you would have all heard of Department of Financial Services. It's part of the Ministry of Finance. And they were in the forefront of implementing something known as Pradhan Mantri Garib Kalyan Package Insurance Scheme, an insurance scheme which was announced for healthcare workers by the Prime Minister as part of his package. And within the first 6 months, DFS, or Department of Financial Services, was able to liquidate almost 3,000 claims, each of 50 lakh each, spread across the country from remotest areas of multiple states, and ensured that the money was credited in the account of next of the kin of the healthcare workers who died while fighting COVID. That's one example, because this was not their core function, but they did it. Similarly, the second example is of your own organization, EPFO. Prime Minister, as part of the Garib Kalyan package, also announced that the workers could withdraw in advance 3 months' wages, which would then ensure some kind of liquidity in the economy because the bank's functioning was disrupted. And I was reading in one of the news that the EPFO West office in Delhi was able to liquidate all claims, 100% claims, within 24 hours of their receipt. So these are just two examples which show that the entire government was working in a coordinated manner to ensure that not only is the pandemic managed, but the effect, the impact of the pandemic is also mitigated. So these are the reasons why we should be recounting the tale of how COVID was managed and what are the lessons for public policy and governance. That having been said, I would now share my presentation with you. We sharing this. It is already yes. Okay. Can you see the slide now?
Yes, sir.
Okay. It's next. Okay. Perfect. So this is the story of the COVID pandemic in India. You would see that we witnessed three waves. The first wave is from 19th of May till the end of November. The peak was on 17th September 2020. And when we say peak, it means the day when nationally we got the highest number of cases, roughly 1 lakh cases, slightly less than 1 lakh cases a day. So this happened in July, August, September, October, November 2020, the first wave. Most of us were not directly affected by the first wave because the numbers were smaller and very few of our relations or our friends actually suffered during the first wave. The second wave is this. It started around 2nd February 2021, reached the peak on 7th May 2021, and declined by August 2021. So basically, February to August 2021 was the second wave, and this wave was far more challenging because on a single day across the country, India received more than 4 lakh new cases. 4,14,188 fresh cases coming every day. So you can imagine the kind of pressure it would have created on our healthcare facilities, on our doctors, on our nurses, on our ambulance drivers, so on and so forth. The third wave was starting around December 2021, and by 21st January 2022, it reached a peak, which means that on a single day, 3,47,000 cases, new cases, were registered across the country, and by end March 2022, the wave subsided. For popular parlance, the first wave is what was caused by the original virus, that is the Wuhan virus. The second wave in 2021 was caused by the mutated Delta virus. It is known as the Delta wave. And the third wave in 2022, January, February, March, was caused by another mutant virus known as the Omicron. So the wave is also called Omicron. We were able to manage it with something that we call whole of government and whole of society approach. We will discuss this further in this presentation. What is the concept of whole of government and whole of society? So that brings us to the next slide. From the point of view of public policy, what was important was a signal that the uppermost rung of leadership was anchoring this entire effort. So it was front-end leadership by the Honorable Prime Minister. What kind of leadership? It was strategic leadership as well as policy level leadership by the topmost person, that is the Honorable Prime Minister, and the leadership involved not only monitoring regularly the progress of the pandemic and its management, but also of oversight. There is a difference between monitoring and oversight, whereas monitoring is purely quantitative effort of asking questions like how much, where, how far. Oversight is more qualitative, where policy inputs are provided to people who are actually managing the pandemic. How did the Prime Minister do this? He did this by regular engagement with the chief ministers and state health ministers. The question is, why was this regular engagement important? Because in the constitutional scheme of things, health remains a state subject. Therefore, for the union government or central government to do things like procuring medicine, distributing it, procuring N95 mask or personal protection equipment, PPE kits, distributing it to the states, requires a close collaboration with the states. That is why this regular engagement was required. The Prime Minister also said that since it was once in a century pandemic, once in a lifetime kind of health crisis, it could not be managed by governments alone. Therefore, it needed participation of the community. That is why the Prime Minister said Jan Andolan and Jan Bhagidari, everyone's participation. It must become a people's movement. If it is lockdown, people must accept the lockdown, only then it will be successful. If it is vaccination, people must willingly come forward for vaccination, only then it will be successful. The Prime Minister also used this crisis as an opportunity to promote Make in India and Make for the World in the spheres of research, development, and manufacturing of vaccines, diagnostic kits, and drugs. Similarly, decisions were taken timely, which means that the pandemic was changing on a day-to-day basis. Therefore, day-to-day decisions were important, and whatever decisions needed to be taken at the appropriate level of the minister or the cabinet were taken without any delay. So, what was the mechanism which was created to ensure that everything happens in time? A group of ministers was created for guidance to multiple stakeholder ministries. I just gave you the example of Department of Financial Services and Ministry of Labor, EPFO. There were other ministries like Commerce, Ministry of Home Affairs, External Affairs. So everyone need to work in a harmony, in tandem. Therefore, group of ministers was necessary. Similarly, there was a group of secretaries which was chaired by the cabinet secretary, and the secretaries of the relevant ministries were there. These groups were meeting almost on a weekly basis. Then there were 11 empowered groups which were headed by secretaries to expedite decision making. The empowered groups were meeting on a daily basis. So while GOMs and COS met on a weekly basis, the empowered groups met daily. Then, to ensure that decisions were based on scientific evidence, there were technical groups. The first one of those technical groups was Joint Monitoring Group under the Director General of Health Services. Then there was a National COVID Task Force in ICMR, which is Indian Council of Medical Research. Then there was a National Expert Group for Vaccine Administration. This group consisted of scientists who and doctors who could advise that if and when the vaccines become available, because this group was made when the vaccines had not even been manufactured. So this group was made and started functioning in anticipation of vaccines becoming available. And they gave guidance on how they would be distributed, how would vaccination be prioritized, so on and so forth. Then there was National Technical Advisory Group on Immunization, NTAGI, again, as I said, for science-based management of the pandemic and evidence-based management. Similarly, there were regular reviews with the state governments that were conducted by Ministry of Health, and central teams sent by the Ministry of Health, Government of India, assisted the states. We, during 2.5 years of the pandemic, issued 180 advisories to assist and handhold the state governments. So it was a huge exercise, but there was an institutional framework for this exercise. So what were the core capacities that we focused on? The core capacities were point of entry and community surveillance, because this was a pandemic which was global. Therefore, we need to ensure that all the points of entry into our country, that is airports, seaports, land crossings, must have active screening and isolation of suspect COVID patients. So this was being done for the first time. So this was one core capacity which was created. The second was testing infrastructure. Until and unless we test people, how would we know who's suffering from COVID, who is not? You would have all heard of RT-PCR tests. Prior to the COVID pandemic, our capacity of RT-PCR test across the country was extremely limited. Pre-pandemic, we had a capacity to test 100 samples in the entire country. Imagine 100 samples a day in entire country through RT-PCR tests. But by the time we were in January 2021, our capacity had increased to 21 lakh tests per day across the country. So from 100 tests to 21 lakh tests per day. So this was another core capacity which was created. Then infrastructure preparedness. When you have a pandemic, people will fall sick. Some of them will remain in home isolation and will get cured. Others will have to be admitted to hospitals. So you need hospital beds, you need ICU beds, you need oxygen beds, you need more ambulances, you need ventilators. So all this infrastructure was prepared. Logistics augmentation. This is another core capacity. I was just talking of oxygen and ventilators. It also ensured that we erected PSA plants. These are pressure swing absorption plants which capture air from the atmosphere, convert it into oxygen and nitrogen, and push the oxygen into medical gas pipeline in hospitals, which then goes to each bed. Even today, when you go to hospital, if someone is admitted among your friends or relations, you will see these pipelines coming down at each bed. So that is the medical oxygen setup of a hospital. Then personal protection equipments, N95 mask, medicines, their buffer stocks. So this was also created. But nothing can function until and unless you train people, retrain people, repurpose the existing human resource. So that was another core capacity building of human resources, capacity building of doctors. For example, a normal MBBS doctor who is, say, posted in a village in Bareilly in Uttar Pradesh, or who's posted, say, in a village in Coimbatore in Tamil Nadu, they were not critical care specialists. They did not know how to, as they technically call it, intubate a patient. Intubation means the patient requires oxygen. You put two tubes so that the oxygen through a cylinder or the medical gas pipeline goes into the patient and assists his lungs. So therefore, that kind of training was done under this capacity building of human resources. But you also need a good communication strategy. You must tell people what is happening on a daily basis and why they should not be afraid. What are the precautions that they should adhere to? What is the behavior which is expected of them? So targeted and focused communication. And lastly, when the vaccines became available, ramping up the vaccination, because we were at that point in time a country of 140 crore people. So 1.4 billion people. And if you look at the vaccination, it was being given from 12 years upwards. And eventually we ended up delivering 2.2 billion vaccine doses, 220 crore doses of vaccine. So that was another core capability that we focused on, which helped us in managing the pandemic. Yes. Okay, so this is, the three-tier COVID infrastructure that we created across the country. At the lower tier were COVID care centers. These were basically places where people could be isolated. For example, not everyone has a house which has multiple rooms. So suppose there are 4 people in the house, there are only 2 rooms and 2 people are sick, then you need to at least give 1 room for their isolation. So the government created makeshift facilities in hostels, hotels, schools, stadiums. The most famous example, which has been written about internationally, is of Bombay, where in one of the largest slums of the world, a facility was created for isolating patients. Another example that is less written about are the railway wagons donated willingly by the Indian Railway, which were then used with the help of oxygen cylinders as isolation facilities. So that was the lowest tier. No doctor was there. This was just an isolation facility so that the patient does not spread the virus. The second rung was people who had moderate clinical symptoms. For example, they had fever, they had difficulty in breathing. So there were dedicated COVID health centers. Here there was an advanced life support ambulance as well as beds with oxygen. And third was dedicated COVID hospitals. These were meant for severe and critical patients. And these facilities had doctors, nurses, ICUs, ventilators, oxygen support. So in total, India created and repurposed 24,000 COVID related health facilities, including hospitals and isolation centers. We created 18 lakh isolation beds. We created 5 lakh 18,000 oxygen supported beds, 1 lakh 45,000 ICU beds, 64,000 ventilators. Now, this is very important. For those of you who are interested in, trivia, prior to the pandemic, from the time of independence, all government hospitals in India in totality had around 6,000 odd ventilators. 6,000 ventilators in all government hospitals from independence till 2020. Within 2.5 years of the pandemic, the government of India was able to supply 64,000 ventilators to government hospitals. So look at the kind of effort which was done. Similarly, a large number of isolation beds for children were also created. If we look at medical oxygen, because most of you would have heard during the second Delta wave, people were in search of medical oxygen. Hospitals were saying that we are running out of medical oxygen. Before I explain the numbers on this slide, let me tell you that prior to the pandemic, the total requirement per day of medical oxygen in India across all hospitals, private as well as government hospitals, was around 1500 to 1600 metric ton per day. Now that 1500 to 1600 metric ton increased to almost 3000 metric ton per day during the second wave, that is the Delta wave. So what did the government of India do? They established 3,900 PSA plants. I told you these are the plants which are inside the hospital. They capture air, atmospheric air, convert it into oxygen and nitrogen, and use the oxygen, pump it into the hospital's medical gas pipeline. Similarly, more than 4 lakh oxygen cylinders were distributed by the union government to the states, and 1 lakh 13,000 oxygen concentrators were given. These are bedside machines for individual patients, and they supply oxygen to the patient at the rate of roughly 5 liters per minute. So that is the overall effort which was done by Government of India. Major learning from the pandemic's second wave was that below the district level, in roughly 770 odd districts that we have in our country, medical facilities are in a fairly inadequate state. District level, you have district hospitals, so it is well equipped, but below district level at subdivisional, taluka, mandal level, there are very weak health infrastructure. So Government of India announced a totally new centrally sponsored scheme, Ayushman Bharat Health Infrastructure Mission, popularly also known as PM Abhi. This was a 5-year scheme. This was announced in 2022 with a 5-year outlay of 64,000 crores Indian national rupees. What did it visualize? Public health labs and infectious disease hospitals would be created across the districts. We would create a IT-enabled disease surveillance framework. There would be surveillance at all airports and seaports 24/7, a network of diagnostic and research labs focusing on viruses, that is diseases which are caused by viruses, and biosafety level 3 and biosafety level 4 labs. Because when you handle viruses, you need biosafety level labs so that the virus should not escape out from the lab and infect general people. Then container-based hospitals, 2 container-based hospitals are also coming up as a part of PM Abhi. Network of health emergency operation centers. These are like control rooms at all districts, work 24/7. Whenever there would be a pandemic, God willing, not during our lifetime, but there would be this ability to operationalize these control centers. Then National Institute for One Health. This is coming up in Nagpur, in Maharashtra, because we realize that there are diseases which are of zoonotic origin. What does that mean? It means diseases which originate in wildlife. For example, the COVID or novel coronavirus originated in bats, and from bats it came to humans. Therefore, in future, if there are such diseases that will travel from animals to humans, we need an Institute of One Health. Why do we call it One Health? So that we signal that animal health, human health, and environmental health are all part of one concept, that is One Health. Similarly, there were certain emergency packages where states were provided financial assistance. Now we will discuss India's only adult vaccination program, which is the COVID-19 vaccination program. Prior to this, we were experienced in vaccinating young kids or pregnant mothers or lactating mothers, but this is adult vaccination in a mission mode and at a scale that is totally unheard of. As I said, and Uttam also said in the beginning, 2.2 billion, 220 crore doses to be administered in a country of 140 crore people. That itself was a challenging task in the time and at the speed at which it was done. So what were the major areas which saw accelerated action? The first was vaccine development. Vaccine had to be developed, had to be manufactured, only then you could vaccinate people. You could not say that other countries would develop it, I would then buy it from other countries, and till they sell it to me, I am dependent on them. So rather than that, India adopted a proactive approach. It encouraged domestic capacity building, manufacturing, and scientific research, both in the private sector as well as in the public sector. Then there was a fund which still is, it's known as the PM CARES Fund. It supported the vaccine development initiative. And in addition to the support of PM CARES Fund, Government of India gave 900 crores to something called Mission COVID Suraksha, which was given to Department of Biotechnology. As I said, the entire government worked as one, and Department of Biotechnology then encouraged private vaccine manufacturers like Bharat Biotech and Serum Institute of India and Biological Events and Genova and multiple such companies to manufacture Indian vaccines against COVID-19. But once a vaccine is manufactured, it has to be approved by the apex regulator of the country that the vaccine is safe, it is effective, and it actually delivers the results that it claims. And who is the apex regulator in India? It is the Drugs Controller General of India, the DCGI. Now, DCGI's processes had to be simplified. So therefore, streamlined and fast-tracked regulatory system for COVID-19 vaccines. A special fast-track system was developed, as all other countries were also developing such systems. US FDA also developed such system. Then expedited permissions for clinical testing, because once a vaccine is manufactured, to demonstrate that the vaccine is safe and it is effective, you have to test it first on animals, then on humans, and then based on that data, the Drugs Controller General gives approval. So all that was done, which led to development of vaccines with focus on safety and efficacy. So now that we have addressed vaccine development as well as regulatory support, we needed to increase the production because India is a vast country, big country, huge numbers. We required large number of vaccines. So this was done through facility augmentation, which means that if Serum Institute had one facility, we asked them what could be the optimal capacity or plant utilization that they could do to produce maximum number. Similarly, Bharat Biotech in Hyderabad was asked, can they manufacture at multiple places? Can they transfer their technology to other manufacturers who could then produce larger number of vaccines? Financial assistance and advance payments were given by Government of India to these private manufacturers. So all this led to ramped up production. And then there was actual rollout of vaccine. So one had to decide who would be vaccinated first. You would have realized that first it was the doctors, the healthcare workers, and not the prime ministers or chief ministers or secretaries of the department who got vaccinated. So scientific prioritization had to be done. Capacity building of vaccinators. There were more than 300,000 vaccinators, 3 lakh vaccinators across the country. So they had to be trained. Comprehensive communication strategy, as we have talked of Jan Andolan and Jan Bhagidari, and equitable access so that all vaccines are available to everyone. Equity and access, particularly of the socio-economic deprived sections or vulnerable population. So that was also done. Then just-in-time logistics management, which is basically use of information technology. EVIN was a platform which was created to track the vaccines from their transportation to their storage, which is inventory management. CoWIN was another platform which all of you or some of you would have used to book your vaccination appointments, to generate your QR code based vaccination certificates, cold chain management, session planning, all this was done by using technology. So this is what I just told you. The first priority was healthcare workers and frontline workers. The second priority were people who were aged more than 60, and then all people who were more than 45, then people who were 18 years and above, then 15 to 18, then precaution doses, which is the third dose, and then vaccination of children 12 to 14, and also vaccination of lactating mothers and pregnant mothers. So all this was done based on scientific evidence and empirical data. This is a very interesting slide. This shows what we were managing. So suppose this is the manufacturer's plant either in Pune or in Hyderabad, from where we were procuring vaccines. From this Pune or Hyderabad plant, the vaccines would travel for batch testing to CRRI Kasauli. Kasauli is in Himachal Pradesh, and to NIB Noida. These were the places where vaccines are tested. It's something like, equipments have ISI brand. So similarly, vaccines are tested and then they are good to go to the market. So from there, using air transport, road transport, they went to government medical store depots. These are depots owned by Government of India, and state vaccine stores. These are owned by state government. There were 60 odd locations within GMSD and state vaccine stores where vaccines went through air transport, road transport. From there, we used reefer vans. They are refrigerated trucks where vaccines are taken to each district headquarters, to the district vaccine store. From there, again in refrigerated trucks, they went to primary health centers. These are centers that cater to anywhere from 30,000 to 35,000 population across the country. From there, individuals carried them in boxes. These are known as vaccine carriers. These are temperature controlled, insulated boxes to the COVID vaccination centers. There were, as I said, more than 3 lakh vaccinators and 3 lakh COVID vaccination centers. From there, session planning was done every day. How many injections would be given, how many vials. Each vial contained 10 doses. So that kind of logistical planning was done. Beneficiary registration was done. Beneficiaries were actually administered the vaccine, and then real-time recording of each vaccination, which means that all 2.2 billion vaccinations have been digitally recorded even today. We can produce those records. So beneficiary acknowledgement, unique health ID was generated, QR code based certificate was given to the beneficiary either on her or his mobile phone or a printout, and then you would recall that the vaccinator would ask you to wait for anywhere from 15 minutes to half an hour after the vaccine was administered to you. Why was that done? To ensure that there was no AEFI. AEFI means adverse events following immunization. Some people would have fever, some people would have anxiety, some people may have some other adverse reaction. So therefore, you were told to wait for half an hour at the vaccination center. And then there was a national dashboard which produced various reports. So this is the whole process of just-in-time approach that we followed. So as I told you, more than 3 lakh vaccination centers, 3 lakh vaccinators. But to ensure that those 3 lakhs were present every day, we trained more than 10 lakh vaccinators so that we have a system which can look at exigencies. 65% of those 2.2 billion doses were administered at rural vaccination centers. So this is the problem of equity that I was referring to. The deprived sections, the marginalized sections, they should also get vaccine. So 65% doses were in rural vaccination centers. Just-in-time approach I've just told you. Then we also had near to home and workplace vaccination centers so that we are able to reach larger number of people. We also dispatched mobile vaccination teams so that elderly could be vaccinated. specially abled citizens, vulnerable groups, transgenders, tribal population. We also had a program called Har Ghar Dastak, where vaccinators went to each house, knocked at the house door, and then provided vaccination services. So here is one vaccinator on a camel top. These are vaccinators crossing a rivulet, and you have a picture of vaccinators traveling in the snow. So in all kind of terrain, our vaccinators did their job. We also, as the director of the academy said, under Vaccine Maitri initiative, supplied made in India vaccine to other countries. There were grants in it, that is free vaccine, commercial sales. Some people were willing to pay us. So those countries we supplied against payment, and a global facility was created known as COVAX. So we supplied vaccine to COVAX facility also. So 17 crore doses of COVID vaccines were supplied by India to 99 countries. And as I told you, we had this very robust digital CoWIN platform. Here is a poster of the CoWIN platform with the Honorable Prime Minister, which we offered to all countries of the world as a digital global good. So the breakup of these 220 crore or 2.2 billion doses. If we look at population that is more than 18 years of age in our country, 92% people were fully immunized. Fully immunized means that they received both the first as well as the second dose. If we look at population from 15 to 18 years, 73% people were fully immunized. That is, they received both the first and the second dose. If we look at people who are 12 to 14 years of age, then 70% were fully immunized. This kind of progress has not been achieved in any country with a large population. And when I say large population, I would mean countries like Brazil, South Africa, even USA. So none of them had this kind of percentage coverage of COVID vaccination. You see, vaccination, how did it help in COVID management? You would see that the second wave or second surge that I referred to earlier, also known as the Delta wave, took 49 days to reach the top, that is 7th May. And then while declining, Delta wave took 68 days. So 49 days to reach the peak, 68 days to reach 10% of the peak. Why? Because at that point in time, this graph that you see, this blue line, this is the graph of vaccination. The vaccination was very low during Delta wave. So people were not protected. They were not immune to the virus. So therefore, it created that kind of havoc. If we look at the third wave, where we were receiving more than 340,000 cases a day, it took only 18 days to climb and 24 days to recede. So therefore, the impact of the third wave was reduced because of the high rate of vaccination. So this is what vaccination does. It modifies the disease. It does not completely stop the disease, but it modifies the disease so that the mortality, that is the death, reduced, and the hospitalization, that also reduced. If we look at the second surge, you will see the same, graph. 117 days in total, both climbing up and coming down of the second wave, that is Delta wave, whereas only 42 days for the third wave, which is the Omicron wave. And if you look at the number of cases, so you will see 19 lakh 43,000, 1 crore 94 lakh 31,743 cases. during the Delta wave and 77 lakh cases during the Omicron wave. The partially vaccinated people, that is people who had received one dose during Delta wave, were only 10%. This number had increased to 90%. People who had received one dose. That is why the impact was less. Fully vaccinated were only 2% during Delta wave. This fully vaccinated figure became 65%. So therefore, hospitalization and deaths reduced. The deaths during the second wave were 2,52,000, whereas during the third Omicron wave, they were only 27,000. And in addition, there were certain late deaths which were recorded later on. There were 16,000. The case rate was 1.29, case fatality rate, this is called CFR, that is the 1.29% of all cases ended in death, whereas it was 0.35% during the Omicron wave. So you would see that it was largely vaccination which helped a great extent. So what are key lessons for public policy and governance? What the pandemic taught us was that we need to be agile in our policy formulation if we have to face any crisis successfully. It need not be a health related crisis. It could be any other crisis, but you need to be agile. What does agile means? It means you need to be proactive. You have to immediately take steps. You have to anticipate. You have to be preemptive. You have to preempt things from happening. If you anticipate that this would happen, then you must prepare for it so that it should not happen, or even if it happens, you are well prepared. You must also have a graded approach. You should not proceed on the assumption that one size fits all. An approach towards the pandemic that works in Kerala may not work in Nagaland. So therefore, you have to be graded and more nuanced in your approach. So that is what agile policy formulation means. It also means that you must learn from your mistakes and you must modify. So this is a quality that we must inculcate. At times we hesitate to accept that certain interventions or certain steps have not yielded the desired results. If they have not yielded the desired results, we must modify. We must say, yes, this did not work. So this is agile policy formulation. Then we come to whole of the government and whole of the society approach. Let us first look at whole of the government approach. In very simple words, whole of the government approach meant that management of COVID pandemic was not the sole responsibility of the Ministry of Health. We were responsible. We were the prime ministry. We were the nodal ministry. But we were not the only responsible ministry. Therefore, whole of the government means that Home Ministry, Commerce Ministry, Industry Ministry, External Affairs Ministry, Labor Ministry, they all helped us. That is whole of the government approach. The entire government working as one harmonious entity. What is whole of the society approach? It means that people must take political and social ownership of whatever is happening. For example, if people start opposing vaccination, which they did in various countries of Europe and America, then the entire vaccination program suffers. So therefore, you must engage with the local community, with the local opinion leaders, and ensure that whole of the society is in tandem, working in harmony with the government. Plus, you also need a coordination between Government of India and the state governments, because as I told you, health remains a state subject. So whole of the government and whole of the society approach is extremely important. For human resource, it is important to repurpose existing human resource because you cannot always hire new people. It takes time. So you need to retrain, repurpose the existing human resource. You need to also repurpose existing physical infrastructure. I just gave you the example of railway wagons being used as isolation facilities for COVID positive patients. So that is repurposing of a existing physical infrastructure. Repurposing of human resource, I gave you the example of a normal MBBS doctor who is not MS or MD being trained in certain aspects of critical care medicine so that they could work effectively in the rural environment. It is also called role shifting, where your role shifts during the duration of the crisis. Then you come back to your original role. So all of us must be equipped and trained for this repurposing and role shifting and innovative use of existing resources. The fourth point is we all must embrace technology, not only information technology, but all kind of technology that would lead to efficiency and transparency in our organization. The examples of embracing technology at a national level in the COVID pandemic was the use of even, I told you, for tracking the movement of vaccines, COVID for generating QR coded vaccination certificates. Then there was a mobile app that the government developed, Arogya Setu, which would tell you the number of COVID positive patients within a 1 year distance as the crow flies, within 5 year, within 1 kilometer distance, 100-meter distance, 5 kilometer distance, so on and so forth. Then e-Sanjeevani, which is a telemedicine platform or a tele-OPD platform where a patient sitting at home can consult with a doctor. And then ABDM, which is Ayushman Bharat Digital Mission, where a ecosystem is created for digital delivery of health services. The fifth point is encourage and facilitate in-house research, collaboration, investment in research and development, and human resource. Because if we do not do indigenous research and indigenous manufacture, we would always be dependent on foreign countries, and that dependency can then adversely impact the sovereignty of the country. So what did we do? I referred to Mission COVID Suraksha, which was a mission to encourage indigenous manufacture of vaccine, establishment of biosafety level 3 labs across the country. Because developed countries have multiple such labs, we had only one in NIV Pune, National Institute of Virology Pune, but during the pandemic we sanctioned more and they are now coming up. Similarly, biosafety level 3 manufacturing facilities where vaccines could be manufactured using hazardous virus particles. And the DOPT, as I said, whole of the government approach, they developed iGOT platform for online training and certification on different skills, which is presently also being used widely. Similarly, all your attempts to succeed require a very well thought out communication strategy. You must know how to communicate in English, in Hindi, in regional languages. So a communication policy or a communication strategy for the crisis is required. We formulated a communication policy for COVID pandemic. It must have slogans where people can emotionally relatable material. I will give you some examples of the slogans that the Honorable Prime Minister used. He said, "Jab tak dawai nahi, tab tak dhilai nahi." till the time that you do not have a vaccine, you must not be lax. So how do you say this, what I have just told you in English, in simple Hindi words? This is the slogan, jab tak dawai nahi, tab tak dhilai nahi. Similarly, he said, do gaj ki duri, mask hai jaruri. We must maintain physical distance and wear the mask. And once the vaccine was available, the Prime Minister said, dawai bhi, kadai bhi. While you must get vaccinated, you must also adhere to COVID appropriate behavior. You should also be in a crisis, ensure that all wrong news, all factually incorrect news, all myths must be busted, must be contradicted in a timely manner. And that brings me to my last slide. You must look at process reforms to ensure that you have the ability to address a crisis. So what are these process reforms? They must make the processes simple. They must make processes less time consuming. They must encourage efficiency, and they must ensure that the marginalized sections are not left out, inclusive. For example, Government of India said we would procure equipment in the initial stages of the pandemic from anywhere in the world. So how do you procure? In less time, you need an emergency procurement guideline. So they were formulated. This was a process reform. They were a relaxation of what we know as GFR, General Financial Rule. So this was a major process reform of the COVID pandemic. Similarly, accelerated regulatory approvals, I referred to them when I talked about the Drugs Controller General. They were also a major process reform. Then doorstep and workplace immunization. The immunization teams will go door to door to deliver COVID vaccination. This had never happened in vaccination in India. So this was also a radical process reform. Similarly, you must have a grievance redressal mechanism and proactive public disclosure mechanism. So how did we do it? We had a 24/7 helpline, COVID helpline. Anyone could give a ring and take information. There was a COVID India portal. Those who had access to a PC or a computer or a smartphone could see different data of the state, of their district, sub-district level on COVID India portal. Then we put in public domain all adverse event following immunization reports. How many people actually fell sick after receiving the vaccination? So that report was also there. So this was a proactive public disclosure. In case of India, this point is something which may not apply globally, but it does apply in India because of our culture. We must emphasize our traditional values of sacrifice and of common interest to motivate our workforce and the community. Because right from school, we are told, and in college and in our peer groups, that we must be helpful. We must help our friends, our community, our village, our mohalla, going out of our family. We have those values inculcated in us from school, within our family. So we must appeal to these values during the times of crisis. How Prime Minister appealed to this? When he said that we would have a Janta curfew, this was a new concept. This was pre-lockdown. No one knew that lockdown was coming. But the Prime Minister prepared the country for this lockdown by saying, let us impose a curfew of our own free will, Janta curfew. Then he said, let us encourage our doctors and frontline health staff by sounding thalis and by clapping, thali and tali. This was again something unique the entire country at a designated time, sounding thalis and clapping, showing solidarity with their health workers. Then the Indian Air Force helicopters were used to do, flower petals were showered on hospitals and health facilities, Pushpa Varsha on frontline healthcare workers. Involvement of faith leaders. This was something which was very effective. I still remember in one of the districts, Mewat, also known as Nu, in Haryana, the offtake of vaccination was fairly poor. Similarly, it was poor in certain villages of Nagaland. There, the administration involved the local faith leaders, and then the vaccination increased. Lastly, this is an individual lesson that we must all try to follow. How far we are able to do it, that would vary from person to person, but we must consciously try to do it. Don't be obsessed by your circumstances. Don't be overwhelmed by your circumstances. This is something that we must try to imbibe. So if we are not to be obsessed, not to be overwhelmed by our circumstances, what should we do? We should try to overcome these circumstances. And how should we overcome these circumstances? By emphasizing what I can do, what you can do in your individual capacity, and then do it with full force, with full vigor and passion. So if 100 people in an organization are not overwhelmed by their circumstances and they try to overcome the circumstances by doing the task given to them with full vigor, the working of the organization improves. And that brings me to the thank you slide. Thank you.
It was so intense and the contents were so well organized. We had heard of whole of government approach, but whole of society approach is slightly new, and the way you have put it across makes complete sense that for any kind of public policy interventions, both of these aspects are equally important. You talked about political and social acceptance, you talked about learning from mistakes, you talked about repurposing and role shifting, you talked about embracing all type of technology. That was quite interesting, sir. Ensuring coordination, learning from communications, and giving due importance to the traditional values. These are certain things which deeply resonates, and you have connected so well with us, sir. Thank you so much, sir. Much appreciate the way you have presented and the time you have taken in putting this PPT, sir. No wonder इतना टाइम आपके पास था कहां सर वो कोविड के टाइम में वेर यू वेर एबल टू strategize and put in things so perfectly well that at least many of us are here today. Thanks to you, sir. With this, it's time for a few questions, sir, if you permit. We are running a bit late, but even then, I would like to take 3-4 questions, if you permit, sir. Can I go ahead, sir?
Yes, please. Yes, please.
Okay. Sir, the first question is slightly confusing to me also, but the question is, there is a confusion, rather debate, about the fatalities in India going by the WHO statistics and those that we released. Would you like to throw a light on how did WHO go so wrong in reporting the fatalities in India?
Let us first see how India reports fatalities. Or in fact, let's see how India reports births and deaths. And then we will come to how WHO did it and what was the issue there. We have a legal structure for reporting births and deaths in India. There is a act under which births and deaths are reported right from the Gram Panchayat level upwards. And at the Gram Panchayat level, it is the Gram Panchayat Secretary, known under different names in different states. In some states, he is called Panchayat Sevak, in some states, Panchayat Secretary. He or she then reports it, then it is aggregated at the level of the district, then aggregated at the level of the state, then it comes to the Registrar General of India, the RGI. Again, it is a part of a legal scheme of things. So prior to the pandemic, this was also happening. During the pandemic, it also happened. So that is the first aspect we need to keep in mind. You will understand why I am telling you this once I complete the answer. The second aspect we need to remember is that the Honorable Supreme Court of India said that Government of India, since it has notified COVID-19 as a disaster under the Disaster Management Act, therefore it must provide financial payment to the next of the kin of the people who have died because of the COVID pandemic. Why am I saying this? Because apart from the legal scheme of things, the Honorable Supreme Court of India was also monitoring the COVID deaths in the country by insisting that next of kin of all those who have died must be given a compensation, which was 50,000 rupees. And multiple times, chief secretaries of states were called physically to Supreme Court to satisfy the Honorable Court of the process adopted for identifying the deaths and payment of compensation money. India, in fact, was the only country in the world where judicial scrutiny of COVID deaths was taking place at the highest level. Having said this, the COVID India portal reported finally, after the third wave was also over, around 5.5 lakh deaths, whereas people who received the financial assistance as a compliance of the Honorable Supreme Court's ruling were around 7.50 lakhs, which means that even if we take the higher limit of 7.50 people who actually received financial compensation as a compliance of Honorable Supreme Court's order, so that is the number. Now let us come to WHO. WHO said that we will not accept the RGI, Registrar General of India's figures of deaths for that year. We would project the deaths for India and some other countries based on a mathematical formula. WHO's mathematical formula gave a number of 45 lakh deaths, which they later on said could also be, up to 48 lakhs. So you have 5.5 to 7.5 lakhs death, depending on whether you take the number which was reported through RGI or the number who received financial assistance, and you have this 45 lakhs that WHO did based on a mathematical formula. So Government of India engaged in continuous correspondence with WHO and told them that since there is a legal and statutory framework under which death figures are compiled and are shared with WHO, therefore these figures should be accepted and not something that is based on projection. One is actual figure, other is projection. Projection also based on a formula about which there were certain lacunae which we separately pointed out to WHO. Since this was not getting reconciled, the Constitution of India has a provision for National Council of Health and Family Welfare. This is a council of health ministers of all states of India, headed by the Union Health Minister. the union, that is the government of India, called a meeting of this council, and this council unanimously passed a resolution. And mind it, in this council, there were health ministers from states that were ruled by a political party different from the political party that ruled the government of India. And they all unanimously agreed that WHO must go by the figures provided by RGI through the Ministry of Health and Family Welfare. And this resolution was actually taken by the Union Health Minister and read in WHO headquarters in Geneva. He read it personally. I was present there in a meeting of WHO member states. That meeting is called World Health Assembly. It happens once every year in May, June. So India's Union Health Minister in that World Health Assembly rose up and addressed the WHO and said that this is one area where we do not agree with WHO, and this is the unanimous resolution of the health ministers across all states, which I am sharing with you. So this is the specifics of the question that you asked me.
Thank you, sir. So eloquently and convincingly explained, sir. And this is an eye opener, sir. The way India was being monitored by judiciary and no other country in the world. Thank you so much, sir. Following up on this question, sir, and the way you said that human mind forgets unpleasant experiences, probably the question arises from there. Has India learned from the hardship of COVID, or are the lessons fading with time? How is the country reshaping its public health infrastructure to become more resilient in the future pandemic, if at all?
And in certain slides of my presentation, I did refer to certain interventions that were triggered by the learnings of the pandemic. For example, the Pradhan Mantri Ayushman Bharat Health Infrastructure Mission, which is a 5-year mission to create health facilities and labs at sub-district headquarter level. So that's one. The second is this whole focus on One Health, how viruses and diseases travel from animals to humans, from human to humans, or how viruses get mutated because of the climatic impact. So for the first time, nationally, we are establishing this Institute of One Health, where cross-cutting studies and research would be done by veterinarians, by human health doctors, by people working in climate, so on and so forth. So these are two examples, but there are multiple such examples which have which can be quoted, but since time is limited, so maybe we will leave it for further discussion.
Sir, thank you so much, sir, and much appreciate your time and affection with us, sir. We have learned a lot, and possibly will request your presence sometimes again in future, sir. Thank you so much for sharing time with us, sir. I would like to thank our director, my team who of reimagining governance, who has been able to knit up all the exercises to bring you here. And it was such a pleasant hearing you, sir. And thank you to all the audience for a patient hearing and posting the questions well in time. Thank you so much, sir. Much appreciate your presence.
Thank you. I also thank Director Kumar Rohit. Special thanks to you, Uttam, to Sagar here, and to all the participants who joined. Thank you. It's a small world, so we will meet again.
Certainly, sir. Thank you so much, sir. Have a great evening.